Good afternoon, everyone. I'm Dr. Naga from Navya. I welcome you all to this long-awaited webinar on multidisciplinary management of carcinoma stomach with Dr. Rakesh Mittal and Dr. Bhushan Balgat. Welcome, sir. I request all the participants to keep their microphone on mute so that we can continue the discussion. And then in the end, we will give an opportunity to ask questions. That time you can you can unmute and speak, please. So, Dr. Rakesh Mittal, I welcome you to this webinar, sir. He is a senior pediatric and medical oncologist from Bangalore, ex-deputy director of TMH Varanasi, and Dr. Bhushan Walgat is consultant oncosurgeon with the Sahyadri Hospital, Pune. So Navya is a cancer informatics and patient services company that leverages technology to provide personalized evidence-based cancer treatment plans to individual patients. This has been helpful to the patient as well as to the physicians who can use the opinion of the TMC NCG experts in the cancer care of their patients. Now we are also working with state government institutions and hospitals such as the Assam Cancer Care Foundation, wherein we are working alongside the doctors there without affecting their work, and we are in fact empowering them with summarized data of their patients along with the NCG recommendations, and also we are providing the expert opinion for complex cases wherever they require. So this has been towards strengthening their cancer care services. In addition, we are conducting these webinars, which is more of a knowledge sharing and experience sharing platform. And I welcome all the participants for this today's webinar. Dr. Mittal is a medical oncologist, senior pediatric and medical oncologist with nearly 30 years of experience in oncology. He is trained from Kidwai Institute of Oncology, Bangalore. He has worked in various national and international organizations, and he is also involved in the various NGOs as volunteer and advisor. He is mainly associated with the Indian Cancer Society, Karnataka, and he has done a lot of research work and presentation and publications, and he is associated with Navya since 5 years. I welcome you for this webinar, sir.
Thank you, Naga.
Dr. Bhushan Balgat, he is consultant oncosurgeon from Sahyadri Hospital, Pune. He is trained in surgical oncology from SMS Medical College, Jaipur, and in surgery from GMC Aurangabad. He has secured second rank in the university. Key areas of interest are GI, head and neck, and gynec surgeries. He is an avid orator, and he has been a regular speaker at various gatherings, conferences, public awareness events, and all. And he has presented research papers at various events. He has received travel grant for his research paper presentation to Japan in the Japanese Surgical Society and Thyroid and Endocrine Neoplasm. He has published 14 research articles in the peer-reviewed national and international journals, and he is associated with Navya since 2.5 years. I welcome you for this webinar, sir. Dr. Bhushan Balgat, I welcome you, sir. And
thank you, sir.
Yeah, and thank you both for sparing your valuable time and accepting our invitation. And we will start with the presentation of the cases. So what we will do is like we'll present the case, and in between, if you want to have any opinion or any detail you want to share, or you want more information, you can please stop in between, and then we can share that information, sir. And then you can comment on the expert opinion, or you can give us your comments on those aspects. Okay, sir?
Yeah, fine.
Yes.
Okay. So, so the first case, the patient is 61 years old, male patient, who have the history of diabetes type 2, hypertension, and hypothyroidism. The complaints were incidental finding on October 2023. So patient had a history of gastritis past 3 years, and they have done endoscopy, which showed gastroesophageal reflux disease. The patient was on regular follow-up and was taking symptomatic treatment at that time. But last year, during regular follow-ups, test showed a non-healing ulcer and Yeah. So the test showed a non-healing ulcer, and caregiver verbally confirmed that the biopsy showed precancerous state. However, the patient was on symptomatic treatment on that time also. So first they have done one endoscopy which showed incisura ulcer surrounding proliferative mucosa on October 3rd, 2023, and a biopsy was taken from the stomach, which showed adenocarcinoma. Again, there was another endoscopy done, which showed 2 centimeters stomach body ulcer along lesser curvature at incisors. Uh, there is another repeat biopsy done from that gastric ulcer, which again showed it's a adenocarcinoma, and cancer grade was 2. So they have done a PET CT scan, which showed 4.1 into 1.4 centimeter distal body pyloric antrum stomach wall thickening with SUV uptake of 3.7, perilesional fat stranding, and few perigastric lymph nodes. There is no evidence of malignancy elsewhere. So from this PET CT scan, the stage was question mark stage 1 with a question mark of T1N0M0. And on October 16, 2023, the patient have taken TMC NCG Navya online expert opinion, and Navya recommended surgery with subtotal gastrectomy or total gastrectomy along with D2 lymphadenectomy. Treatment with concurrent chemoradiation therapy and upfront radiation therapy was not indicated or recommended at that time. So the patient have underwent upfront surgery with subtotal gastrectomy, D2 lymphadenectomy, and Bilroth 1 anastomosis and feeding jejunostomy on October 28, 2023. The operative note showed mobile growth at lesser curvature near the antrum and distal part of the stomach. There was no ascites or peritoneal involvement. The tumor site was body and gastric antrum. The size of the tumor was 3.3 into 2.1 into 1 centimeter, and the margins of the surgery was negative. Proximal distal duodenal recur edge, lesser omentum, greater omentum margins examined. There was subserosal involvement, and there was lesser omental adipose tissue infiltration. So they've resected around 45 lymph nodes, out of which one was positive, and the malignant disease shows it's an adenocarcinoma. Additional information shows tumor penetrates the subserosal connective tissue without invasion of the visceral peritoneum or adjacent structure. That makes it T3. Tumor infiltrates the lesser omental adipose tissue, and the cancer grade was 2. Lymphovascular invasion was positive, as well as perineural invasion was there. Pathological TNM stage showed stage 2B, T3N1M0. And patient's general condition was, patient ECOG was around from 0 to 1, and patient is able to do his daily activity without assistance, no significant disease related symptom, and patient doesn't have any resource constraint. So, yeah.
Dr. Balgat, now I would request you to take us through, I think, the surgical aspects of this case management. Maybe you can comment on the earlier procedures that were done, maybe the challenges that you can see, and then you can also take us through what best can be done going further.
Yes. So basically, first of all, there were two upper GI endoscopies done. I assume that uh, two scopies were done maybe to confirm or to get a second opinion, which is uh, yeah. And ulcer over the incisura was found, which was around 3 to 4 centimeter. Looking at that, I would not have suggested a endoscopic ultrasound because there's a gross ulceration already present, and it is staged as stage T1 as per the FDG PET. So I think it should have been staged either T2, T3, or there are a few perigastric lymph nodes also. So the staging preoperatively, we should have a better staging could have been done in this case. Like the TNN stage look like upgraded rather than T1N0. Apart from that, sir, depending on the surgery, discussing about the surgery, the subtotal gastrectomy or total gastrectomy, instead a partial or subtotal, one of the two, I would recommend in this case instead of a total gastrectomy. D2 lymphadenectomy is the norm now. D1 lymphadenectomy was the previous thing. So basically, D1 means removing lymph nodes along the stomach's greater and lesser curvature only, that is station 1 to station 7. And D2 includes removing nodes along the principal arteries, which include the celiac artery, splenic artery, the hepatic artery, and the gastric arteries. So clearance of the lymph nodes is very important in stomach cancers to avoid radiation in the post-operative stage. If the lymphadenectomy is incomplete, then radiation has to be given. And in this case, the lymphadenectomy seems to be very much complete because 45 lymph nodes have been removed. The amount of lymph nodes a CS stomach surgery requires to be removed is 16, and desirable as per NCCN guidelines are 30. So we are
Okay.
much more than that. 45 is much more amount. And the hepatic nodes, splenic nodes, and the D2 nodes all have been addressed. So in this case, the surgery seems to be quite complete. The only thing I doubt whether Billroth 1 was done in this case, because to explain to the audience, Billroth 1, Billroth 2, and Roux-en-Y are three types of reconstruction that can be done in a case of distal or total gastrectomy. Sorry, in distal gastrectomy. In total gastrectomy, we don't have Billroth as an option. We directly do a esophagojejunostomy. In distal or subtotal, we have Billroth 1, 2, and Roux-en-Y. So in Billroth 1, we directly anastomose the proximal part of stomach with the duodenum first or second part. In Billroth 2, we anastomose stomach to the jejunum. And in Roux-en-Y also, we anastomose proximal part of stomach to the jejunum in a Roux-en-Y manner, where the bile acid reflux is the least. So in this case, if a subtotal gastrectomy was done, I think a Billroth 1 anastomosis would have been very difficult to do. I think a partial or distal gastrectomy with a Billroth 1 might have been done with a D2 lymphadenectomy. And a feeding jejunostomy is required in a few cases, especially when a total gastrectomy is done, because the nutritional component is hampered a lot because we don't have a pouch of stomach. Not even the proximal part of the stomach is there. Hence, a feeding jejunostomy should be done in a case of total gastrectomy, especially. Not every case of distal or subtotal requires a FJ. So these were my opinions regarding this case, sir.
So going forward with this case, is there any role of surgery, sir?
No, sir. The surgery seems complete totally.
Complete.
Surgery,
Okay.
surgery is done.
Yes, sir. Now, Dr. Mittal, I think now you will be coming into picture for the medical aspects. So I request you to please comment on that. Maybe you can, if you have anything to add in the beginning, also you can add, and
No,
then
I
we can
think
move on to the corrects.
surgery was very much indicated in this case, and it has been done. Proper surgery and proper dissection has been done, and D2 dissection of the lymph node is very adequate, as Dr. Bhushan has said. Now the question comes whether the patient need any adjuvant therapy or not. So this is a case of stage 2B, where with a D2 resection. So I would prefer to give here adjuvant chemotherapy, which is definitely indicated in this case. There is no need for chemoradiation, as it is a D2 resection, and D2 resection, we don't need any adjuvant radiation. So definitely we will need chemotherapy. And in the gastric carcinoma, adenocarcinoma, we have not too many medicines. We have basically fluoropyrimidines and platins and then taxanes. So these are the which drugs which can be used. So here the best combination is, I would say, either capox or folpox, which is recommended, and patient should be started on adjuvant chemotherapy for 6 cycles. And then depending upon if he complete the chemotherapy without any complication, then he should be on the regular follow-up. What do you think, Dr. Bhushan?
Absolutely, sir. Radiation is absolutely not required, and the protocols that you have said are the standard protocols. And a 3 monthly follow-up for the first year, followed by 6 monthly for the 2 more years, and then yearly is the norm we follow here.
I prefer capox because it is easier to give, because capecitabine is an oral drug, while 5-FU we have to give 24-hour infusional. That is a little cumbersome. So here the patient come only once in 3 weeks time and take oxaliplatin, and rest of the medicine is taken at home. So this is a very convenient regime for the patient.
For capox, sir, for the capecitabine, do you use 14 days followed by 7 days off?
Yeah, 7 days off, 14 days on, 1000 milligram BD, and 14 days and 1 week off.
Okay, sir.
That is a standard. If the patient doesn't tolerate, we can always modify the dose.
Right, sir.
Thank you, sir. For the participants, if you have any questions, you can unmute and ask now, or alternatively, you can put the questions in the chat box so that the experts can look at it and respond to those questions in their opinion. Is anybody having any questions? Okay, then we will go on to the second case. Mr. Mayur, can you please present the case?
So, moving on to the second case, the patient is a female of 63 years old. Patient has a family cancer history of paternal aunt ovarian cancer, and niece ovarian cancer, another niece lung cancer. Patient had comorbidities of hypertension. Patient has issues of GERD, psoriasis, anemia, and patient have underwent Whipple procedure in 1996 and also cholecystectomy in 2003. Patient have a prior history of cancer, periampullary carcinoma is in 1996. So she underwent Whipple's procedure followed by 6 cycles of chemotherapy. The clinical details of the chemotherapies are unknown. Currently, the patient have complaints of dyspepsia from June 2022. So patient was experiencing regurgitation of food, difficulty breathing while lying down after eating, frequent hiccups, unpleasant burps with acidic taste, and challenges in bowel movements despite being on medication for a year. So they've done an endoscopy which showed stomach distal body, lesser curvature, ulcerated lesion, narrowing of lumen, due to which the scope could not be passed forward on August 30th, 2023. The biopsy from the stomach showed adenocarcinoma grade 3, cancer grade 3, and they have done one CT abdomen pelvis, which showed 7.5 into 2.2 centimeter stomach lower body antrum lesion, narrowing of lumen, distension of stomach, mild perigastric standing, and no evidence of malignancy elsewhere. They have done PET-CT as a metastatic workup, which showed 6.2 into 2.3 centimeters stomach pyloric lesion with SUV of 6.8, distension of stomach, narrowing of lumen, right level 1, level 2 cervical lymph nodes, right lower paratracheal mediastinal lymph node, mediastinal blood pool, and there was no other malignancy elsewhere. So the radiology note indicates right level 1, left level 2 cervical lymph nodes are likely reactive. Left lower paratracheal mediastinal lymph nodes are likely reactive. The clinical TNM stage was assessed as stage 2B, T3N0, M0. Patient started chemotherapy, neoadjuvant chemotherapy, from September 12th, 2023. X-ray chest showed no evidence of malignancy on November 9th, 2023. They have done CT abdomen and pelvis on November 10th, 2023, which showed 6.0 into 2.0 stomach lower part lesion, narrowing of lumen, mild perigastric stranding, multiple small bowel mesentery lymph nodes. After that, they have done CA125, which was 8.2, and carcinoembryonic antigen, which was 4.80 at this CEA trended upward from August 29th, 2023 till October 11th, 2023. CA 19.9, it was 12.7, which trended upward from August 29, 2023 till November 11, 2023. So CBC, KFT, and LFT are all within normal limits. Patient's ECOG score is 1 and able to do the daily activities without assistance. The symptoms currently includes weakness, fatigue, bitter taste in mouth, and weight loss of 10 kilos. And patient doesn't have a resource constraint.
There was no surgery.
No surgery.
Again, Dr. Bhushan Balgat, I would request you to give your points. There was obstruction, there was she was having regurgitation and other symptoms. So any role of surgery, and if surgery was not taken up later, like what was the indication, like why, and can you give us some more ideas about that?
So basically, after
Just
Whipple procedure, there are two ways we can reconstruct the three organs which have to be reconstructed. That is the pancreatic duct, the hepatic duct, and the stomach, the proximal stomach. So in traditional way, it is a PHJ, that is the pancreas, hepatic, and G. In a sequence, they are reconstructed. But we have seen a few, or not few, we have seen some cases where we can reconstruct the loop in a Roux-en-Y manner. The advantage of that is the regurgitation of the pancreatic and hepatic juices which occurs in the stomach has been seen to cause gastritis and gastritis-induced gastric cancers. So Roux-en-Y helps reduce this complication, which is seen in the traditional way of reconstruction of PHG manner. So that was one which is now being done at a few centers across the world, the Roux-en-Y Whipple. Secondly, the difficulty in doing the re-surgery for CS stomach in a post-Whipple case is the anatomical variation which we find there. And reconstructing after removing the stomach in the already reconstructed stage would be a challenge for the surgeon. Apart from that, the tumor has not responded to 4 cycles so much that it should have responded to. So that's a challenge when it comes to the medical oncology part, whether to change it to the another protocol, whether to do some other test and try some other therapy amongst the targeted or immunotherapies, or hand over the patient to the surgeon first and then do so this is a borderline or a dilemma case where a discussion is must in such cases.
Dr. Bhushan, can I ask you something? I
Yes, sir.
don't have much experience with the surgery, but in after Whipple, is it difficult for the gastric surgery? Like in
Yes,
the future, like in this case, has the Whipple been a causative factor for this malignancy?
it could be a factor, sir, because
Mhm.
there's no way we can prevent the bile and the pancreatic juice reflux in the stomach
Mhm.
done in a traditional reconstruction manner. So it could be a factor of having a second malignancy. The
How much
juices which
stomach is removed in Whipple? How much part of the stomach?
Sir, if there are two ways we can do a Whipple regarding the stomach resection. One is the pylorus preserving, and one is the pylorus resecting. So
Okay.
PRPD and PPPD. So
Mhm.
not the whole stomach is removed, just the pylorus or removal or pylorus not removal is
Mhm.
the norm. Nowadays, pylorus preserving is being done to prevent the dumping syndrome.
So what do you think happened in this case? They preserved or they removed?
No, that doesn't matter, sir. The reflux which has happened. So I think the pylorus might have been removed in this case.
Okay.
Correct. Sir,
Okay.
coming to the medical oncology part, I think
Now, this
only
patient
about
definitely the neoadjuvant chemotherapy was indicated because it was locally advanced case, and they have given this Folfox chemotherapy, but unfortunately, it has not shown much response. So, I, in my opinion, the chances of getting further response, it doesn't have much chance that if we change the chemotherapy or if we uh, give more cycles, I will definitely consult the surgeon whether he can do the surgery or not. This will be my approach in this case. What is your opinion, Dr. Bhushan?
Definitely, sir. Surgery, if possible, first putting a laparoscope in to look because the disease has not responded. I would put a
Hmm.
scope in to see any peritoneal disease which is missing. We would take a cytology, and then we would see assess whether resection is possible in this case.
So what happened,
sir.
Naga, in this case?
Yeah, can show the case. So we have the information up to up to November 23, sir. I think where the decision was pending. Treating oncologist recommended to continue therapy for 2 more cycles to make 6 cycles, and then because surgeon said that only 50% chance of success for surgery. That's where it was stopped. So whether to go for surgery or chemo or palliative care was the question that was pending. And yeah, like we after giving the opinion, we don't follow up, sir. We
So
unless the patient comes back.
so if surgery can be done, that will then the further treatment will depend upon the result of the surgery. But if the
Yes,
surgeon
sir.
feels that it cannot be done, then the patient is only for palliative treatment. Or
Palliative care, yeah,
or
correct, sir.
like palliative chemoradiation can be offered to the patient, but it will not be a curative treatment.
Yes,
Dr.
sir.
Bhushan,
No
your comment?
curative treatment.
Yes, sir.
Thank you, sir. Any questions from the participants? Okay. We have one question from Ms. Pooja. I think we can address it in the end. Uh, we can move on to the third case. Yes.
So the third case is a 62 years old female with the first presentation on January 2023. The patient complains of difficulty in eating and vomiting. They have done an endoscopy which showed 4.0 centimeter antrum ulcer, GE junction esophageal ulcer. They have done a PET CT scan which showed 1.1 centimeter gastric lesion with SUV of 3.0 pyloric antrum gastric rugae, lesser curvature, stomach cardia blunting, extensive perigastric fat stranding, extension to gastroesophageal junction, anteropyloric region complete luminal obliteration, perigastric along gastroepiploic left gastric vessel lymph nodes, perinodal fat stranding with the largest of 0.8 centimeter and SUV uptake of 2.4 centimeter, periportal peripancreatic along splenic vein, autocaval, left renal hilar lymph node, largest of 0.9 centimeter in periportal region with a SUV uptake of 2.8. There was few bilateral lung oblique fissure nodules, largest 1 into 0.5 centimeter in right lung with a SUV uptake of 1.6, and there was no evidence of malignancy elsewhere. The radiology note showed gastric lesion as a primary malignant disease and perigastric lymph nodes as metastasis. Periportal autocaval left renal hilar lymph node were suspicious of metastasis, and lung nodules were question mark benign, and the nature cannot be identified. So they have done gastric biopsy, which showed Signet's ring cell adenocarcinoma with a cancer grade 3. MSI was stable. They've done HER2/neu testing, which showed negative. PDL1 positive, greater than 1%. They have done chemotherapy with neoadjuvant intent with docetaxel, cisplatin, and capecitabine from February 17, 2023 to May 2nd, 2023. The response assessment as a PET CT scan was taken, which showed 1.1 centimeter gastric lesion with SUV of 3.0, pyloric antrum gastric rugae, laser curvature, stomach cardia blunting, extensive perigastric fat stranding, anteropyloric region complete luminal obliteration, perigastric along gastroepiploic left gastric vessel lymph nodes, perinodal fat stranding, largest of 0.5 centimeter with SUV of 1.7, periportal peripancreatic along splenic vein, autocaval, left renal hilar lymph nodes, largest 0.5 centimeter in periportal region with SUV of 2.7. There was a 0.8 into 0.5 centimeter liver right lobe segment 5 near gallbladder fossa lesion, which is a non-FDG avid lesion. Few bilateral lung oblique fissure nodules, largest 1.0 into 0.2 centimeter in the right lung, which is again non-FDG avid, and there was no evidence of malignancy elsewhere. The radiology notes said no significant change in pyloric antrum gastric rugae's body, stomach, laser curvature thickening. There was a decrease in perigastric lymph nodes, complete resolution of bilateral lung oblique fissure nodules, and liver segment 5 lesion was a new finding. So they have done US guided FNAC from the liver, which showed no evidence of malignancy. The patient went ahead with a surgery of total gastrectomy with D2 lymphadenectomy and esophagojejunar anastomosis and jejunectomy and feeding jejunectomy on June 8, 2023. The site of the tumor was distal stomach, lesser curvature, and focally reaching greater curvature. Final margins of the surgeries are negative. There were 10 lymph nodes resected out of which 0 showed metastasis. There was subserosal involvement. Serosa was 0.2 centimeter away from the tumor. Malignant disease showed signet ring cell adenocarcinoma with a cancer grade of 3. Pathological tumor size was 8 into 2.5 into 0.2 with a negative lymphovascular invasion and positive perineural invasion. Tumor regression score was 3. There was extensive residual cancer with poor response, minimal therapy-related changes seen. They've done IHC, which showed CD68 positive, highlighting the histiocytes. CK7 was positive and EMA was also positive. The IHC negative findings were CDX2 and CK20. Pathological TNM stage after the surgery came out to be 2A, which is a T3 M0 M0. The patient underwent
I
for
think we can just stop here and let
sure,
us
sir.
discuss the treatment till.
Sure.
So, Dr. Bhushan, what do you think about the surgery?
Sir, the surgery, the nodes, as we can see, are 10 lymph nodes removed.
Yeah,
So I can
only temporary, inadequate.
yeah, it's inadequate, sir.
Mm. But the surgery part, otherwise, was you can call it D2 lymphadenectomy, Dr. Bhushan?
I don't think so, sir.
Hmm?
No, sir. For D2
Yeah.
lymphadenectomy, easily we can. It's not 10. 10 is a very minimal amount of
Yeah,
nodes which have been.
that is what I was wondering, because we can't keep name it as a D2 lymphadenopathy.
Yes, sir.
So anyway, it was like not a surgically complete. So we'll
Yes.
call it a R1 resection. Would you?
Oh, yes. R1 or a D1 lymphadenectomy only, sir.
Yeah,
R1.
yeah. R0 or
Yeah.
D1. That would be more better.
Yes.
D1 lymphadenectomy. Yeah.
Yeah. Okay. So, okay, continue.
Yes. So after the surgery, they have underwent adjuvant chemotherapy with fluorouracil, leucovorin, and oxaliplatin from July 13th, 2023 to September 2023, 22nd September 2023. So patient was on regular follow-up after that from October 2023 till January 2024. On January 2024, the patient didn't have any complaint, but it was surveillance detected. They have done a PET CT scan which showed few lung, right upper lobe, lower lobe lesions with largest of 1.9 into 1.6 centimeter, SUV of 8.1. The right lung mediastinal pleura, coastal thickening, and largest of 0.3 centimeter with SUV uptake of 3.3. Few left lung oblique fissure lesion, nodules with largest of 1.0 into 0.2 centimeter, which is again non-FDG avid. Right paratracheal, prevascular, subcarinal, bilateral hilar lymph nodes, largest 1.4 into 0.7 centimeter in subcarinal region with SUV of 3.9. There was gross right pleural effusion, right lung near complete collapse, mediastinal shift towards the left side, right hemidiaphragm displacement, and there was no evidence of malignancy elsewhere. This scan was done on January 3rd, 2024. The radiology note indicates, as compared to the previous PET CT scan dated May 24th, 2023, right lung pleura thickening, oblique fissure nodules, right lung collapse were new findings, and complete resolution of liver lesion. So there was so the clinical TNM stage at this point will be stage 4 with NET, NEN, and M1 since there was a lung lesion. So the patient started palliative first-line chemotherapy with carboplatin and nab-paclitaxel from January 18, 2024. They have done a PET CT scan which showed right lung bronchovascular interstitium fissures thickening with SUV of 2.7, 0.2 centimeter right lung costal mediastinal pleural thickening with SUV of 3.0, third rib anterior end SUV of 3.5, D9 to D11 vertebral body right lateral aspect lesion, which is FDG avid, right paratracheal prevascular subcarinal bilateral hilar lymph nodes with the largest of 1.3 into 0.6 centimeter in subcarinal region with SUV of 2.4. There was moderate right pleural effusion, and there was no evidence of malignancy elsewhere. The radiology note indicates right lung bronchovascular interstitium fissures thickening, which is suspicious for lymphangitic carcinomatosis. Right lung costal mediastinal pleural thickening, which is likely metastatic disease. As compared to the previous PET CT scan, complete resolution of right lung upper lobe, right lung upper lower lobe lesion, left lung oblique fissure sub-centimeter nodules, decrease in costal mediastinal pleural thickening, mediastinal lymph nodes, right pleural effusion, and the vertebral lesion was a new finding. So the patient have low hemoglobin of 10.7, a WBC of 10.10, which is high, and platelet of 453. The patient have low sodium level 133. Serum chloride was low 97, and creatinine was 0.43, which was low. Patient have high alkaline phosphatase 195, and the ECOG score of the patient is 1. She's able to do daily living without assistance. Current symptoms include loss of appetite, weight loss, weakness, fatigue, and severe chest pain. And patient doesn't have any resource constraint.
Sir, Dr. Mittal, would you like to take up this case and comment
Yeah.
first?
So it is now we are dealing with a metastatic gastric cancer, which initially was not a metastatic, but later on, after initial treatment, had become a metastatic disease. Now, as a metastatic, it becomes incurable. So our treatment options are only as a palliative treatment. And we must explain to the family very well that our intention is palliation only. And in the palliation, we will do the symptom control. And in the bargain, if we can have the improvement in survival, that is also our aim. But how much we can improve the survival will depend upon the response which patient will get on our palliation chemotherapy. But here I am little worried about the severe chest pain part. You have mentioned that patient is having severe chest pain. Now I have to find out whether it is a cardiac pain or it is due to this bone metastasis. So this need to be investigated. So first of all, I would like to take opinion from a cardiac physician to rule out any cardiac event. And then if it is not a cardiac event, then we'll take it as a pain from a metastatic bone, for which I think because of the severity of the pain, maybe I would like to give some palliative radiation to the involved bone. And then patient has already been started, I think, on palliative chemotherapy. But here I would like to add nivolumab as per the NCCN guideline. This should be added in the palliative setting, because also although they recommend irrespective of the PD-L1 status, but here the PD-L1 was more than 1. So I will definitely like to add, and family has no financial burden. So I will definitely like to add nivolumab for whatever benefit it can give to the patient. So
there is one. Yes, sir, please continue.
No, I'll carry on.
Sir, there is one question from Dr. Revant. So pre-chemo PET shows lung and attackable nodes, and curative versus palliative intent of treatment in view of PFS of only 3 months. So what is your comment on that?
Where can you repeat the question?
Sir, pre-chemo PET CT shows lung and attackable nodes and are present, and what is the choice, whether curative versus palliative intent of treatment in view of PFS of only 3 months?
So it is a palliative intent only.
It will be palliative intent.
Yeah, the treatment is all palliative intent only. There is no curative intent. Once the disease has become metastatic, particularly the lung and bone, there is no curative treatment for this patient. I think Dr. Bhushan will agree with me.
Absolutely, sir. Absolutely. I think that is the reason why maybe he has not removed the amount of nodes required during surgery.
But at that time, there was no evidence of distant metastasis.
There was only some lung nodules at that time, sir.
Yeah, but they were like the SU value was low, so they were not considering them as a metastatic.
Yes, sir. Yes, sir.
Yes, yes. Dr. Revant, if you still have any doubts, you can please unmute and ask, sir. So,
But in
so
these
other
in
than
these
that,
in these cases, it is very important that the treating medical oncologist or whosoever is the treating doctor, they should sit with the family and they counsel them regarding the intent of the treatment. Because many of the times the family keep thinking that we are giving the treatment for cure, while it is not for cure, and many times they keep taking treatment thinking that patient will become all right. So this is very important on the part of treating physician, that they must be told that the intention is palliative only.
thank Dr. Balga, do you want to add anything for this case?
I think the role of surgery initially in this case appeared to be curative. Had it been considered metastatic initially, the only indication was obstruction in this case. So I think in this case, a surgeon's role is minimal.
Okay,
Yeah,
sir.
now the surgeon role will be only if there is any further obstruction or bleeding, then the surgeon
sir.
role
Yes.
will become there. Otherwise,
Okay, sir.
he is not for any curative treatment is not indicated.
So there is another question. What are the most common complications observed during the MDT of gastric cancer? How are these managed across different specialties?
Dr. Bhushan?
So, complications regarding the patient or complications or the audience wants to ask whether the various issues which are raised during MDT or the confusions which occur. That I'm not sure what she is meant to ask. If regarding the complications regarding the treatment is most commonly we see a bleeding ulcer. Patient has an HB of 2, patient is not ready for surgery. In those cases, radioembolization by intervention radiologist is the commonest which we deal with here, bleeding ulcer in the CA stomach. Or endoscopic guided, the lasers, argon laser guided the firing of the ulcer can be done. That we see commonly here as a complication in this CA stomach cases. That because we cannot go ahead immediately with surgery, we need to prep the patient. And if she's asking regarding what issues are raised within different specialities, that creates a confusion. I think the most common one is the inadequacy of surgery, which creates a confusion whether to go in for re-surgery, whether to radiate the patient, whether to treat it as a palliative. That is the one common confusion in CS stomach cases in MDT. I think Rakesh sir would add to this.
Yeah, definitely. There are sometimes there are confusion, particularly regarding radiation, whether to give radiation or not to give radiation. So these are but these can be solved when they all specialties sit together and then they reach a consensus. That is why there is a importance of multidisciplinary tumor meeting, where they all sit together with the radiologist and pathologist and reach a consensus regarding, because in medical science there is nothing black and white. There are many gray areas. So many times you have to take a decision which is not acceptable to all, but then you have to go with the consent.
Any other questions from the participants? So I think I think there are no more questions. So I have a couple of requests. One is like for your specialty, if you can give us some highlight of the recent advances in the gastric cancer management, diagnostics, or any other approaches from the medical oncology by Dr. Mittal and from the surgical oncology by Dr. Balgat. I think that will be helpful.
Dr. Bhushan, I think you start with some recent advances.
Yes, sir. In surgical part, robotics is the most recent advance. Where we have a lot of Korean and Japanese trials which have shown to be better on a robotic side for even distal and total gastrectomy. The trials are still going on. Part of the results are out. So that is one disadvantage. Advance. The second is the use of ICGs or the use of various different modes during endoscopy or use of endoscopy during surgery helps localize small tumors or post neoadjuvant tumors, which helps surgeon or during the surgical case. So these are a few disadvantages advances we have.
So
Yes, sir.
in the medical oncology, I think the research is more on the genetic part of the thing. Like whole medical oncology is now looking at the genetic changes, and more molecules are being coming into the market now. So there is a lot of research going on, but till date we haven't find out any breakthrough, particularly in the treatment of metastatic CS stomach. But there are new molecules are coming which are being tried. They have shown advantage like nivolumab and pembrolizumab, and there are this is ramucirumab. So there are new molecules are coming, and now there is some new classification according to genetic makeup of the patient. They are also coming. So in the coming years, we will see a lot of molecules, but the main breakthrough I will consider is only if it can really make a difference in the survival. Otherwise, increasing the life by a few months by spending lakhs of rupees, I personally is not in favor of that kind of treatment, at least in India, where we spend lakhs and crores of rupees to gain few months. That is not really worth it. But yes, if patient can get good life, 3 year, 4 year, or maybe curative, then definitely it will be worth it. We have to wait for a few more years where we can get some good news regarding some new molecule.
Okay, sir. Sir, one more request is yeah, if there are no more questions, I think you can just give us a take-home message to all the participants on gastric cancer management. I think from the surgical oncology, Dr. Balgad, you can start, and then we can end with Dr. Mitra's message.
Take-home would be, as a surgeon, we should not directly take each and every patient to OT directly as the patient comes. Every patient has a right to get into a multidisciplinary discussion first, followed by the best decision. Because there are a lot of neoadjuvant therapies, neoadjuvant immunotherapies are coming up in CS stomach.
Yeah.
Even we have seen NCCN guidelines has recently added that if the tumor totally disappears after neoadjuvant immunotherapy, they don't require surgery. There's an option of that. So as surgeons, we should not take every patient directly to the OT without discussing with our co-medical oncologists. That's my message for all.
Yes, sir. Okay, Doctor. Dr. Mitra.
Yeah, it is as Dr. Bhushan has said, we must discuss all the cases in the tumor board meeting because it is a multidisciplinary approach. And chemotherapy has definite role in adjuvant setting as well as in neoadjuvant setting. But in metastatic, we have chemotherapy plus immunotherapy, which can give us some life advantage of few months. So it is worth trying, but the trials are still going on. Lot of work needs to be done. But CS stomach is a very challenging tumor, like all the malignancies. It is one of the very challenging tumors, and I am sure, like if somehow it can be picked up early, definite good results are expected in these patients.
Thank you, sir. I think we can conclude the webinar with this take-home message. It has been a wonderful session with nice input from both the experts with a detailed conversation about the surgical and medical aspects, and it has been really a good learning session for us. And I thank both of you for sparing your valuable time and taking time out and explaining so many things to us and sharing your knowledge with us. And I thank the participants for attending this webinar and taking advantage of the learnings from the leading experts of this field. And I thank all of you, and we can conclude this session. And one more request is for participant, you will get a survey once you exit the Zoom. Please respond to the survey and give your feedback on the webinar. With this, I thank all of you, and we'll conclude the session.